Hey everyone, and welcome back to the Deep Dive. I'm Harvey.
And I'm Donna.
And we're both MCCQE reviewers. So if you're a Canadian medical student getting ready for that exam,
We are here to help.
we're going to be breaking down all those major concepts covered on the exam.
Try to make it a little less intimidating.
Yeah, make it a little bit more fun.
And a lot more understandable.
So you can really grasp those concepts and feel confident going into that exam.
And of course, we're
Yeah.
using reliable sources like stat pearls to
Definitely.
make sure we're giving you accurate information.
Yes. And of course, just a quick note before we get started.
Yes.
Everything we discuss here is for educational purposes only.
Right.
This is not medical advice, so always consult a qualified healthcare provider if you have any health concerns.
Always.
Okay, with that out of the way,
Let's dive in.
let's dive in. Today, we're going to be tackling 3 major vascular conditions that you'll definitely need to know for the MCCQE:
Oh, yeah.
abdominal aortic aneurysm
Aortic dissection.
and peripheral artery disease.
Yeah, these are all conditions that can go downhill really fast.
Yes, they can.
If they're not caught and managed properly. So making sure you understand them thoroughly.
Yeah.
Absolutely crucial for any aspiring physician.
So let's kick things off with abdominal aortic aneurysms, or AAAs.
Okay.
These are so interesting because they can be completely silent
Yeah,
until they become a serious emergency.
it's true.
You know, a patient coming in for a routine checkup and you discover this ticking time bomb
Yeah,
in their abdomen. Talk about a high-stakes situation.
exactly. And AAA is basically a ballooning of the aorta in the abdominal area.
Right.
The biggest concern with that is that it might rupture,
Right.
which can be life-threatening.
It can be.
The larger the aneurysm gets,
Yeah.
the thinner the wall becomes and the higher the risk of rupture.
That makes sense. It's like blowing up a balloon. You know, the bigger it gets,
Right.
the more likely it is to pop.
That's a great analogy.
Thanks.
And just like a balloon, some materials are weaker than others. If the aortic wall is weakened by things like smoking, high blood pressure, or even certain genetic conditions,
Right.
it's going to be even more susceptible to rupture.
So what kind of patient should we be thinking about when we are considering someone might have a AAA?
Okay, so
Who's most at risk here?
age is a big one. As we get older, our blood vessels naturally become less elastic and more prone to damage. Men tend to develop AAAs more often than women,
Okay.
and those with a family history of AAAs are also at an increased risk.
Okay, so age, gender, family history.
Yep.
What about lifestyle choices?
Absolutely. Smoking is a huge risk factor for AAA.
Oh, yeah.
It damages the lining of the blood vessels
Right.
and contributes to the weakening of that aortic wall.
Okay, so if a patient comes in with any of those risk factors, what is our first step in checking for an AAA?
Usually ultrasound is the initial screening tool.
Okay.
It's non-invasive, relatively inexpensive, and can give us a good idea of the size and location of the aneurysm.
And let's say an ultrasound does detect an aneurysm.
Yeah.
What happens next?
It depends on the size and characteristics of the aneurysm.
Okay.
Small aneurysms that aren't causing any symptoms may just need to be monitored regularly with ultrasound.
Uh-huh.
But larger aneurysms, or those that are growing rapidly or causing symptoms,
Yeah.
might need further investigation with a CT scan.
Okay, so ultrasound for that initial screening and CT for more detail if needed.
Yep.
What about treatment? When does surgery become a necessity?
So the decision to recommend surgery is based on several factors,
Right.
including the size of the aneurysm, the patient's overall health, and whether they're experiencing any symptoms. For men, surgery is typically recommended if the aneurysm is 5.5 centimeters or larger.
Okay.
For women, the threshold is usually 5 centimeters.
Gotcha. And what are the surgical options for treating in AAA?
There are 2 main approaches: open surgical repair and endovascular aneurysm repair, or EVR.
Okay.
Open surgery involves making a large incision in the abdomen and replacing the damaged section of the aorta with a synthetic graft. EVAR is a less invasive procedure where a graft is inserted through a small incision in the groin
Oh.
and guided up to the aneurysm using X-ray imaging.
So EVAR sounds like it would be a much easier recovery for the patient.
Yeah.
What are the downsides to that?
Well, EVAR is not suitable for all patients.
Okay.
The anatomy of the aneurysm needs to be appropriate for the procedure.
Right.
And there can be long-term risks associated with EVAR, like the graft shifting or leaking. Open surgery, while more invasive, tends to have a lower risk of those long-term complications.
That makes sense. It's always a balancing act,
It is.
weighing the benefits and the risks for each individual patient.
Exactly. And that's where clinical judgment and experience really come into play.
Yeah.
You know, understanding these nuances is so crucial for making those informed decisions about patient care.
All right, so we've covered the basics. of AAA's definition, risk factors, diagnosis, and treatment.
Okay.
Now let's move on to another potentially deadly condition that often gets misdiagnosed.
Right.
Aortic dissection. What makes this condition so tricky?
So aortic dissection is a tear in the inner layer of the aorta, the main artery that carries blood from the heart to the rest of the body.
Right.
It's often described as a sudden, severe tearing or ripping pain.
Oh, wow.
And it can be very deceptive because the pain can mimic other conditions, like a heart attack.
So a patient might come in complaining of chest pain, but it could be something far more serious
Exactly.
than a simple heart attack.
Yes.
What are some other clues that might point toward an aortic dissection?
Okay. Well, besides that intense pain,
Right.
which can radiate to the back, neck, or jaw,
Wow.
other signs could include a difference in blood pressure between the arms,
Okay.
a weak or absent pulse in one or both arms or legs,
Oh, wow.
and neurological symptoms like weakness or numbness.
So a thorough physical exam, paying very close attention to blood pressure and pulses.
Absolutely.
Electrical here.
Yes.
What about diagnostic tools? What can we use to help us confirm this diagnosis?
So imaging studies are going to be crucial here. A chest x-ray might show widening of the mediastinum, which is the area between the lungs that contains the heart and aorta.
Right.
However, the gold standard for diagnosing aortic dissection is a CT angiogram, which provides detailed images of the aorta and can clearly show the tear.
And what about those two classification systems that we mentioned earlier, Stanford and DeBakey?
Yes.
Why are they important?
These systems help us classify aortic dissections based on the location of the tear, which is really important for determining the appropriate treatment.
Right.
The Stanford system is more commonly used and has two types, type A, which involves the ascending aorta, and type B, which involves the descending aorta.
So type A involves that part of the aorta closest to the heart.
Yes.
That sounds like it would be a more dangerous situation.
It is. Type A dissections are considered surgical emergencies.
Right.
Because they carry a much higher risk of complications like rupture or damage to the heart valves. Type B dissections, on the other hand, can often be managed initially with medication to control blood pressure,
Okay.
but they still require close monitoring and may eventually require surgery.
So understanding those classification systems is really important for making those quick decisions
It is.
about patient care.
Absolutely.
What are some of the key risk factors for developing an aortic dissection?
Okay, so hypertension or high blood pressure is the most significant risk factor.
Okay.
It puts a lot of stress on the aorta,
Right.
increasing that risk of a tear. Other risk factors include atherosclerosis or hardening of the arteries,
Right.
connective tissue disorders like Marfan syndrome, and certain congenital heart defects.
So if a patient comes in with uncontrolled hypertension and sudden severe chest pain radiating to their back,
Yeah,
that's a major red flag
big red flag.
for a potential aortic dissection.
It demands immediate attention and investigation. Early diagnosis and prompt treatment are crucial for improving outcomes.
All right, we've covered two pretty intense conditions so far. Let's switch gears a bit and talk about peripheral artery disease, or PAD,
Okay.
which affects the arteries in the limbs, usually the legs.
Right.
This one might hit closer to home for some listeners
It might.
because it can manifest as leg pain or cramping during exercise, something a lot of people might just brush off as a normal part of aging.
That's a great point. PAD is often overlooked or misdiagnosed,
Yeah.
but it's a significant health concern because it's a strong indicator of underlying atherosclerosis, which can affect arteries throughout the body, including those supplying the heart and brain.
So PAD is not just about leg pain, it's a warning sign
Yes.
for other potential problems in the body.
It's like a canary in a coal mine.
Yeah, exactly.
Okay.
Okay, so let's talk about those leg symptoms.
Okay.
What should we be looking out for?
So the classic symptom of PAD is intermittent claudication,
Okay.
which is pain, cramping, or fatigue in the legs.
Right.
That comes on with exertion, like walking,
Okay.
and goes away with rest.
Why does that happen? What's going on in the muscles to cause that pain?
It all comes down to a supply-demand mismatch.
Okay.
When you exercise your leg, muscles need more oxygen and nutrients, which are delivered by the blood. But with PAD, the narrowed arteries can't supply enough blood to meet that increased demand.
So it's like trying to run a marathon with a kink in your garden hose.
Right.
You know, the muscles are calling for more oxygen, but those narrowed arteries are restricting that flow.
That's a great way to put it.
Thanks.
That lack of oxygen or ischemia is what causes the pain. It's the
Yeah.
body's way of saying, hey, we're not getting enough blood flow here.
That makes perfect sense. So how do we diagnose PAD? Is it just based on those leg symptoms?
While those symptoms are a strong indicator, we do need objective measures to confirm the diagnosis.
Okay.
One of the most common tests is the ankle brachial index, or ABI.
Okay, ABI is a key test here for PAD.
Yes.
Can you explain how it works?
Sure, the ABI is a simple, non-invasive test that compares the blood pressure in your ankle to the blood pressure in your arm. Okay. A normal ABI is 1.0 or higher, meaning the pressure in your ankle is at least as high as the pressure in your arm. But if the ABI is less than 0.9, it suggests that blood flow to your legs is restricted.
So the lower the ABI,
Yeah.
the more severe the PAD.
Generally, yes. An ABI between 0.4 and 0.9 typically indicates moderate PID,
Okay.
while an ABI below 0.4 suggests severe PAD.
Okay, so we've talked about recognizing those leg symptoms and using ABI to confirm the diagnosis.
Right.
What are the main risk factors for developing PAD?
A lot of the risk factors for PI are the same as those for other cardiovascular diseases like atherosclerosis.
Okay.
Smoking is a major culprit, as is diabetes, high blood pressure, high cholesterol, and a family history of cardiovascular disease.
So basically anything that damages blood vessels and contributes to that plaque buildup can increase the risk of PA.
Exactly, and just like with those other conditions, lifestyle modifications play a crucial role in managing and preventing PAD.
Okay, let's take a break there. We've covered a lot of ground in this first section, from the silent danger of AAAs to the deceptive nature of aortic dissection and the often overlooked warning signs of PAD. When we come back, we'll delve deeper into treatment options and discuss some of the latest advancements in the field.
It's amazing how interconnected these conditions really are.
Sure.
You know, we've been talking about risk factors like smoking and high blood pressure.
Right.
And they all play a significant role in the development of both AAAs and PAD.
Yeah,
It really highlights the importance of a holistic approach to patient care.
absolutely.
Yeah,
We can't just focus on treating that immediate problem.
right.
We need to consider the bigger picture
Yeah,
and address those underlying risk factors that are contributing to multiple conditions.
absolutely. Now, before we move on to treatment,
Yeah.
I think it's worth revisiting that analogy of the expanding balloon you used earlier
Okay.
when talking about AAAs.
Right.
It's a good way to understand the physics involved in aneurysm rupture.
Okay.
It all comes down to the law of Laplace.
Which states that the tension on the wall of the vessel increases as the radius of the vessel increases.
Okay.
So as an aneurysm gets bigger,
Yeah,
the tension on the wall gets higher,
right.
making it more likely to burst.
So it's not just the size of the aneurysm, but also the pressure it's under.
Exactly. And that's why controlling blood pressure is so crucial in managing AAAs.
Okay.
By lowering blood pressure, we can reduce the stress on the aneurysm wall
Right.
and potentially slow down its growth.
That makes sense. Now, let's talk about treatment options for PD.
Okay.
We touched on lifestyle modifications earlier.
Yeah.
But what specifically can patients do to manage their condition and improve blood flow to their legs?
So the cornerstone of PD management is lifestyle changes.
Right.
Quitting smoking is absolutely essential
Yes.
because smoking not only damages blood vessels, but also constricts them, further reducing blood flow.
So smoking is like a double whammy for PD patients.
It is.
What about exercise? I know it might seem counterintuitive to recommend exercise,
To someone who is experiencing leg pain,
right?
but I've heard it can actually be beneficial.
You're absolutely right. Regular exercise, particularly walking, can actually improve symptoms of PAD.
Really?
It sounds strange, but exercise helps strengthen leg muscles
Okay.
and improve collateral circulation, meaning the body develops new pathways for blood to bypass those narrowed arteries.
So it's like building a detour for the blood flow.
Yeah.
That's pretty amazing.
Yeah.
Are there any medications that can help with PAD?
Yes. There are a couple of medications commonly used to treat PA.
Okay.
Silestazole is one, and it works by both widening the blood vessels and preventing platelets from sticking together, which can further obstruct blood flow.
So it's a two-pronged approach to improving blood flow.
Yeah.
What's the other medication?
The other one is pentoxifylline,
Okay.
which works by improving the flexibility of red blood cells, making it easier for them to squeeze through those narrowed arteries.
It's like giving those red blood cells a little bit of lubrication
Right.
to navigate those tight spaces.
Exactly. Now, in some cases, lifestyle changes and medications alone aren't enough to manage PAD,
Right.
and more invasive procedures might be necessary.
You're talking about things like angioplasty and stenting?
Yes. Angioplasty involves using a balloon to widen the narrowed artery.
Okay.
And often a stent, which is a small mesh tube, is placed to keep the artery open. In more severe cases, a bypass surgery might be required,
Right.
where a healthy blood vessel is taken from another part of the body and used to create a detour around the blockage.
So for PAD, it's all about restoring adequate blood flow to the legs,
It is.
whether it's through lifestyle changes, medications, or procedures.
Precisely. And it's important to remember that PAD is often a sign of a more widespread problem with atherosclerosis.
Right.
So managing PAD effectively also means addressing those underlying risk factors to reduce the risk of cardiovascular events in other parts of the body.
Okay, let's shift back to aortic dissection for a moment.
Okay.
We talked about how the Stanford classification system helps determine the urgency of treatment. Can you elaborate on why type A dissections require such immediate intervention?
So type A dissections involve the ascending aorta, which is the section closest to the heart.
Right.
This means there's a much higher risk of the dissection extending back toward the heart, potentially damaging the aortic valve or even causing a rupture in the heart itself.
So it's a race against time to repair that tear
Yeah.
before it causes catastrophic damage to the heart.
Exactly. That's why type A dissections are considered surgical emergencies, and immediate surgery is almost always required
Wow.
to repair the tear and prevent those life-threatening complications.
What about type B dissections? Are they ever treated surgically?
So type B dissections, which involve the descending aorta,
Okay.
can often be managed initially with medication to control blood pressure
Right.
and reduce the stress on the aorta.
Mm-hmm.
However, if the dissection is causing complications such as compromise of blood flow to vital organs,
Okay.
or if it continues to grow despite medical management surgery may be necessary.
So even though type B dissections are considered less immediately life-threatening,
Yeah.
they still require close monitoring and potentially surgical intervention down the line.
Exactly. And it's important to remember that aortic dissection is a serious condition with a high mortality rate.
Right.
So prompt diagnosis and appropriate management are crucial for improving outcomes.
You know, we've been talking a lot about the physical aspects of these conditions,
Yeah,
but I think it's important to also acknowledge the psychological impact as well.
absolutely.
Imagine being diagnosed with an AAA or surviving an aortic dissection.
Right.
You know, these are life-altering events.
The emotional and psychological toll of these conditions can be significant.
Right.
Patients might experience anxiety, fear, and even depression as they cope with the diagnosis, treatment, and long-term implications of their condition.
So as physicians, we need to address not just the physical needs of our patients, but also their emotional well-being.
Exactly. We need to provide support, reassurance, and resources to help our patients navigate the challenges of living with these conditions.
Okay, let's switch gears for a moment and talk about something that's always top of mind for medical students.
Okay.
The MCCQE.
Yes.
How can understanding these conditions help students succeed on the exam?
Well, these conditions are all high-yield topics for the MCCQE,
Okay.
meaning they're likely to show up on the exam in some form.
Right.
Understanding the pathophysiology, risk factors, clinical presentation, diagnosis, and treatment of these conditions is essential for answering those challenging exam questions.
So it's not just about memorizing facts,
No.
but truly understanding the concepts
Yes.
and being able to apply that knowledge to clinical scenarios.
Exactly. The MCCQE is designed to assess your clinical reasoning and decision-making skills,
Right.
not just your ability to recall rote information.
What advice would you give to students who are preparing for the MCCQE in terms of studying these cardiovascular conditions?
I would say focus on understanding the key concepts and the underlying mechanisms of disease.
Yeah.
Don't just try to memorize everything. Instead, try to make connections between different concepts and think about how these conditions would present in real-life clinical settings.
That's great advice, and I think this deep dive has been a perfect example of how to approach studying for the MCCQE.
Yeah,
We've gone beyond just listing facts and have really delved into the why behind these conditions.
I agree. And remember, future Canadian doctors, the MCCQE is just one step in your journey.
Right.
The real learning begins when you start applying this knowledge to real patients in real clinical settings.
All right, let's take another break here. When we come back, we'll wrap up our deep dive by discussing some of the latest research and advancements in the field, and we'll leave you with some final thoughts and resources to continue your exploration of these fascinating conditions. Welcome back to the final part of our deep dive into some pretty important cardiovascular conditions.
It's been quite a journey exploring these conditions, and I hope our listeners are feeling more confident about their understanding of them.
Absolutely, and we're not done yet. Before we wrap things up, let's touch on some exciting new research and advancements that are changing the way we approach these conditions.
Definitely. The field of cardiovascular medicine is constantly evolving, and there are always new discoveries and innovations on the horizon.
Let's start with AAAs. We talked about EAR being a less invasive alternative to open surgery. Are there any new developments in that area?
Well, one exciting advancement is the use of fenestrated endografts.
Okay.
These are specially designed grafts with little windows or holes built in to accommodate blood vessels that branch off from the aorta.
So it's like a custom-fit graft tailored to the unique anatomy of each patient's aorta.
Exactly. This allows surgeons to treat more complex aneurysms that might not have been suitable for traditional EVR in the past.
That's incredible. Seems like medical technology is always finding ways to be less invasive and more precise. What about aortic dissection? Any promising research on that front?
Researchers are working on developing biomarkers that could help identify patients at risk of aortic dissection even before they show any symptoms.
So it's like an early warning system for aortic dissection. That could be a game changer in terms of prevention.
Absolutely. If we can identify those at highest risk, we can implement preventative measures like controlling blood pressure more aggressively or recommending lifestyle changes to potentially avoid a dissection altogether.
Okay, let's talk about PA. We know that medical therapy is the first line of treatment. Are there any new medications in development that might offer even better results?
Researchers are exploring new therapeutic targets for PAID, including medications that target inflammation and oxidative stress,
Right.
processes that play a role in the development of atherosclerosis.
So it's not just about widening existing arteries, but also about tackling those underlying processes that contribute to the disease in the first place.
That's right. And there's ongoing research into gene therapy and stem cell therapy as potential future treatments for PET.
Those are some truly groundbreaking areas of research. It's incredible to think about the possibilities. So with all these advancements, what does the future hold for these cardiovascular conditions?
Well, I believe we're moving towards a more personalized approach to medicine where treatments will be tailored to the individual patient's genetic profile and risk factors.
So it's about moving away from a one-size-fits-all approach and towards a more precise and targeted approach to care.
Exactly. And with advancements in imaging technology and minimally invasive techniques, we'll continue to see less invasive and more effective treatment options for these conditions.
Well, this has been a fascinating deep dive into some pretty complex conditions. As we wrap things up, what are some key takeaways you want our listeners to remember?
First and foremost, I hope they gained a deeper understanding of these conditions, from the basic science to the clinical presentation and management.
And don't forget the importance of those underlying risk factors, like smoking and high blood pressure.
Absolutely. Addressing those risk factors is crucial not only for preventing these specific conditions, but also for improving overall cardiovascular health.
And as future Canadian doctors, it's crucial to approach each patient holistically, considering both their physical and emotional well-being.
Couldn't agree more. Remember, medicine is about more than just treating diseases, it's about caring for people.
Well said. Thank you so much for sharing your expertise and insights with us today.
It was my pleasure. And to our listeners, we encourage you to continue exploring these topics, keep asking questions, and never stop learning.
And remember, the MCCQE is just one step in your journey to becoming a skilled and compassionate physician. Thanks for joining us on the deep dive.